So welcome everybody. I'm delighted this afternoon to introduce Dr. Rachel Grob, who is going to be talking to us about long COVID. Before I hand over to Rachel, just a few words of introduction. So Rachel is joining us from the United States this afternoon. She directs the Qualitative and Health Experiences Research Lab at the University of Wisconsin, and also directs the Center for Patient Partnerships, where the focus is improving health by listening to people's experiences with their health and illness. Rachel is also chair for the Global Health Experiences Organization, DIPEX International, and a pioneer of the development of the US-based Health Experiences Research Network, which, like its sister platform here in the UK, Health Talk, researches and shares patient stories. Rachel's going to talk to us today about patient experiences of long COVID. As I'm sure most of you on the call will be well familiar, patients have been at the forefront of identifying and addressing long COVID since it was first reported in the spring of 2020. Rachel in this talk is going to summarize the global impact of long COVID and explore themes that have emerged from qualitative health experiences research in the United States, but then also research that's been conducted globally. A few words of housekeeping before we start. You're all muted at the moment, and we will be taking questions at the end of Rachel's talk. Please do either pop your questions in the chat and I'll be happy to read them out, or if you'd like to ask your question directly at the end, please do raise your hand and Paul or I will unmute you for that. So without further ado, I'm delighted to hand over to Rachel. Thank you.
Wonderful. Thank you, Lisa. It's wonderful to be with all of you. I guess I will say this afternoon, although for me it is still the morning. I am just going to review quickly the game plan, which Lisa already alluded to. I'm going to talk a little bit about what long COVID is and how attention to it was first generated, just to be sure we're all on the same page. Then I'm going to share some narrative evidence from two qualitative studies, one that I co-led with my colleague, Dr. Everett in the USA, and one cross-national study with 8 participating countries, very much including the UK. And then finally, I'm going to suggest some actionable implications from this research, some reasons why narrative approaches are important, and then we'll open things up and have time for questions. So please be ready to engage in conversation as well. That is often the best part. So what is long COVID? It's had a few different names. At first it was called long haul COVID. It is clinically often referred to as post-acute sequelae of COVID, and it has a number of other emerging terms. As defined by the World Health Organization, it is this long-term sequelae that occurs in individuals with a history of SARS-CoV-2, probable or confirmed, usually 3 months from the onset of COVID-19, with symptoms that last at least 2 months, and that aren't explained by an alternative diagnosis, which is important because it's somewhat mysterious, and clinical diagnostics do not reliably tell us that that is what is going on. So rather like HIV and other syndromes, it sort of emerges through a collection of symptoms. And those symptoms, as you can see on this slide, can affect most of the systems of the body. It's got a very diverse presentation, hearts, lungs, really most of our organ systems, and perhaps most importantly, for many patients, at least, the brain. This brain fog and fatigue and other related symptoms are one of the most common manifestations. And you can see here, this is still just a partial list, but these, as my colleague, Dr. Serena Schrager at University of Wisconsin-Madison has emphasized, and I thank her for this slide, these are some of the most commonly documented symptoms that we are seeing in clinical settings and in some of the larger epidemiological studies that are emerging and being published now. A recent systematic analysis of the emerging literature on this that was published just in November of this year estimates that as many as 43% of those infected may experience long COVID for various durations, and there's still a lot of work to determine that. But according to that recently published analysis by Chen et al. An infectious disease journal, we may be seeing as many as 200 million people globally affected by this. And they are still sorting out, the scientific community is still sorting out risk factors, but certainly comorbidities and severity of the illness matter. And I think there's still quite a bit of debate over whether vaccination really is protective or not. The Chen study, which again just came out and tried to really like roll up what's been published so far, said that they consider that inconclusive. So stay tuned. Most relevant for our talk today, however, is this aspect of the emergence of long COVID. Patients have identified, addressed, and researched long COVID really from the very start. And because of the characteristics of the first wave of COVID in the winter and early spring of 2020, many healthcare workers were, of course, infected as they did their essential duties. And so there was also a lot of overlap between people who had scientific training and were experiencing something that, according to the clinical literature, didn't exist. So we saw popping up both publications by scientists documenting, by social scientists documenting the patient-led nature, by patients themselves. We saw survivor core and long COVID support and other long hauler groups popping up to try to legitimize what was going on, develop networks of support and information exchange, and also the development of scientific knowledge. So there's really to the extent that there's any length in the history of long COVID, which is still just a few years old, it is deeply, deeply rooted in patients' own initiatives. And that leads us directly to the consideration of narrative evidence as a valuable resource in understanding and addressing emerging diseases. And I think we all know that COVID is not the first and the last. Long COVID is not the first and the last. So it's incumbent on us to sort of zoom out a bit and think about how we can move from anecdotal stories, which have always existed, to sort of a science of harnessing what we can learn from narrative approaches. And I am going to talk to you today about a method that Lisa already mentioned in the introduction, the Database of Individual Patient Experience, or DIPEX methodology, which is one way to go about doing that. So what is the DIPEX methodology? It focuses on eliciting diverse perspectives. It has a sampling frame, which is part of the rigor underlying the method. And that frame is maximum variation. So making sure that we're not hearing just the modal story, just sort of the belly of the bell curve, and also not hearing just the voices of people who are already structurally advantaged to tell their story and maybe out there on social media and talking to the traditional media or showing up in legislative houses and so forth. We really need to seek the stories of the narratives of people who may be structurally disadvantaged from giving voice and from being heard, given the biases that we have in many societies around who counts and who we really listen to well. We analyze this narrative evidence for both theme and variation to really hear both what is coming up repeatedly and where these stories diverge and give us a really well-rounded and deep sense of what's happening. And then we have designed all of these studies for dissemination so that we can amplify what people are experiencing and make systems work better for patients. And that includes publishing these studies in web-based resources that are free and available to the public. Part of why this matters, and it's such a cogent approach, in my opinion, is because of how illness really happens in the community. And you can see in the red box here that for every 800 people who report symptoms, only about a quarter of those people are going to show up in clinical settings. So we really need to be talking to people where they are in order to understand illness. And that may be particularly true for something like long COVID that is just emerging and not even well understood. So the first study I am going to share with you in terms of insights and results from interviews with patients. This is a one-on-one interview methodology, was funded by the Department of Family Medicine and Community Health, of which I am a part, and supported by the Center for Patient Partnerships, which I do not direct, but which I have been a part of for the last 12 years, very proudly. And that study aimed to identify sort of actionable aspects of narratives. What could primary care clinicians do better in working with patients with long COVID, and how can we increase understanding, and also to really get at dimensions of trust as they underlie the long COVID experience. Here is a snapshot, a picture. We videotape whenever we have permission, which is not always, these interviews. And when we develop the web-based resources, we have clips from those interviews from folks like these on the web. And here's just a little bit of background. We didn't get as much racial and ethnic diversity as we would have liked in this sample. I think the international sample did better. We talked to a lot more women than men, and that reflects we were more skewed than the overall demographic, but more women than men are experiencing or reporting long COVID. And you can see we had a pretty good age distribution there. So what did we learn? We heard a lot about purpose and identity and changes in daily life. Many people we interviewed described how long COVID was leaving them feeling like, quote, less of who I am. There's so much feeling of the loss of thinking you're not going to get better, and then the loss of who you were before you had COVID, said another person. I just want to be me. And I think it's hard too. People ask me, why aren't you better yet? And that makes me feel like a failure. Life profoundly changed for a number of people we talked with. Routines at home with partners and children were profoundly disrupted. Treasured parts of daily life, like making art, cooking, or physical activities, have been abandoned. Driving is for some now, quote, super scary due to distractedness, brain fog, and forgetting to look in the rearview mirror. Work is affected for many people. I was cognitive that when I was doing things wrong at work, said one person, but it's like I couldn't change it or control it, and then I would just shut down. And usually I'm pretty fierce. I get things done. I'm a hard worker. That's the way I was raised. So I felt guilty, and I kept telling them, I'm not anymore the person you hired. A number of people were forced to leave their jobs. I thought I was losing my mind, and I was ashamed of myself, said one in this situation. Another worried that the less she used her brain at work, the worse things would get. Yet she was unable to do the job she had before COVID, And though she got a lawyer, no suitable workplace accommodation had yet been arranged at the time of the interview. People also wonder, will I ever be as smart as I was? Will their cognition return to normal? A great many of those we interviewed singled out brain fog and cognitive issues as, quote, huge and one of their biggest concerns. I don't know, said one, if I will ever be as smart as I was. Not to say that I was super brilliant, but I just feel a lot less smart now. My primary doctor has all the faith in me, though, she added, and said it will come back to you, and I'd love to believe that. People with long COVID are also adjusting to good physical health no longer being their default status. I'm not the same as I was on March 11th, said one person, when we did a lot of walking around and had a fabulous day in the city. I mean, I felt fine. I couldn't even imagine the thought of the next day starting to not feel so great. So I reflect a lot on the fact that there's me before and me after. Doing what was easy before isn't so easy anymore. We were really healthy people before we got ill, said another. Now she says she's just hoping to keep pushing through and maybe get back to where she was. Many people we interviewed spoke about how much changes to taste and smell, which are well-known sequelae of COVID, impact their daily lives. Food rituals are profoundly disrupted, both in terms of being able to cook for oneself and for family and friends, and in terms of being cooked for by others. Numerous interviewees talk about struggling to hide physical feelings of disgust when presented with meals they used to find delicious and know were prepared for them with love. Other struggles include physical difficulty changing one's own children's diapers, being around colleagues who are eating in the workplace, and using shampoos and soaps. We asked about and we heard about both uncertainty and trust in these interviews. We heard a lot about how living with the uncertainty of a newly emerging health problem was difficult. Interviewees talked about how hard it can be to trust themselves. As one of them put it, some of these things that are happening to me, I feel ridiculous trying to explain. I can't taste this. Some of the things that go haywire in my body just seem like flipping. You gotta be kidding. How is this supposed to be real? Like, I don't even believe it. So I feel like an unreliable narrator to myself and to others when I'm explaining. We've got a publication under review now that summarizes some of these dimensions of self-trust being undermined in chronic illness, including long COVID. Another person described how she thought a whole array of symptoms, from difficulty breathing to extreme fatigue to dizziness, were maybe, quote, just in my head. You learn to doubt yourself a little bit that way after a while, she said. It's hard to trust yourself and to know what's real and what isn't. In the context of powerful self-doubt and wondering if long COVID is real or, quote, am I nuts, it matters a lot to be believed by other people. As one respondent put it, quote, feeling believed is huge because sometimes you don't even believe yourself. Our interviewees also talked about how frightening it is to have a new and little understood condition. One talked about how scary it is, saying, I think number one, it's scary because what's gonna happen next? You have like 12 hours of feeling normal, and then all of a sudden you're having electrical shocks through your head, or you're nauseous, or you have a headache, or you can't get your thoughts out. And then when in clinic, they called me a guinea pig because of studies being done, it made it scarier because they didn't really know. They didn't know what to do next or what would help me. Other people we interviewed talked about feeling alarmed and frightened, quote, in terms of not knowing what other neurological processes COVID could impair. Just as being believed is an effective remedy for self-doubt, so too our interviewees emphasized how being accompanied through the long COVID landscape of uncertainty, particularly by clinicians, can bring relief. In the words of one respondent, quote, "With the uncertainty of this, that's got to be a hard one on both ends of the equation for both clinicians and patients. Maybe for me," she continues, "it's just addressing that outright is helpful." Another person also wishes she and her primary care provider could ride long COVID's waves of uncertainty together. She wants her doctor to say, "I don't know much about that, but I know some colleagues who are doing work in that space. Let me get back to you and let's schedule a visit in a couple of weeks." We interviewed a number of people who haven't sought primary care for their long COVID. So the interviews, as I suggested on the illness happens in the community slide, can provide insight about why patients stay silent or stay away from care. Some were worried about risks for COVID and other germs associated with in-person visits, particularly earlier on in the pandemic. "I felt so weak and fragile," said one. "I didn't want to contract anything. I didn't feel like going out and going into a building and indoors with other people," said another. "I was scared to interact with other people, the outside world, with everything going on." Stigma is another big issue. There's more people that are coming out about it, one of our interviewees who spoke about this said, but it's such a stigma about this syndrome, so that's been a really hard part of the journey. Others spoke about not disclosing their long COVID, even to friends and family, for many months, and about how shocked people were when they eventually did find out. Hesitation about disclosing to doctors seems to have a few origins, at least as documented in our interviews. In some instances, people were worried about being dismissed by their providers. In others, reluctance stemmed from, quote, "just feeling like there's not much that's known or can be done. It's scary to me," said one interviewee who had networked with many other long COVID sufferers, "the stuff people are not even telling their docs, but people are frustrated with their healthcare, with healthcare systems not knowing what to do." We're also hearing a good bit of survivor's guilt. There's been so much death from COVID. Those who make it through may be reluctant to validate and get care for their own ongoing illness because they feel so lucky by comparison. "Especially right after COVID," said one person, "I was in, quote, a very deep depression that was tough to get out of because for quite a long time, I never thought I'd be able to do the things I used to do. And that was hard to acknowledge because it's like, what do you have to be depressed about? You came out of it alive." "You had COVID and it was like a cold," said another. "What the hell are you complaining about?" Okay, so that's a bit of what we've heard in the US. I'm going to shift now and tell you just a little bit about our international work on this same topic, and then I'm going to play you a montage so you can hear directly from patients from around the world instead of hearing me just summarize what they said. So as Lisa mentioned, I've been involved with DIPEX International for a number of years. We're an association of academic and nonprofit groups around the world, and we come together to use a rigorous methodology for eliciting, synthesizing, and amplifying narratives to make health and healthcare better. The folks at Oxford and around the UK have been pioneers of this work, and we both publish as that sort of design for dissemination methodology I mentioned, these web-based resources on websites like Health Talk or Health Experiences USA. And we also publish hundreds of articles in the peer-reviewed literature documenting our findings. We got going in the summer of 2020 in response to COVID with a cross-national pilot work really on experiences with COVID overall. And then a number of countries sort of settled in and focused on long COVID. And we've got actually a special issue in Social Science and Medicine, qualitative health research coming out, documenting a number of aspects of these cross-national studies. So keep your eye out for that. In terms of long COVID, 8 countries participated, and you can see them named and their flags here. We did a rapid cross-national comparison of 167 interviews across these 8 countries this past summer in order to generate a montage, which I'm going to show you in a moment, that we were able to share with the World Health Organization, who had a working group looking at long COVID and was really interested in narrative evidence as they built their own World Health Organization response to long COVID. Here are some themes. You will hear these in a moment in the montage, but sometimes it helps to fix in on them a tiny bit ahead of time. Some of them overlap with what you just heard in the US, but some of them are really pulled out here, and I think you'll enjoy hearing these folks speak. So settle in. This is a little bit less than 7 minutes. You won't hear the sound for the first few seconds, so just sit tight while that sound comes on.
Ik kan gewoon niet meer de dingen die ik kon. En dat maakt gewoon het probleem. Voordat ik ziek werd gingen we autovakanties, ver weg autorijden. Maar alles wat je doet is beperkt. Natuurlijk, mijn vrouw heeft ook onder te lijden. Want je kunt niet meer die dingen samen doen wat je eigenlijk al die tijd gedaan hebt. De kinderen idem dito, stoeien, dat soort zaken. Kan het niet met mijn spieren en ik heb gewoon de krachten niet meer voor.
Comecei a sentir uma dificuldade absurda, né? Assim, de não ter interesse para ver um filme, para nada, assim. Eu falei, cara, não consigo focar, não consigo prestar atenção em algumas coisas. Ler jornal, eu sinto essa dificuldade de foco, né? De você se concentrar numa coisa, eu ficar meio que disperso e de esquecer as coisas, de eu combinar. E aí eu comecei a usar post-it de coisas que eu não precisava, assim, não me sentia uma necessidade de fazer isso.
もうお金がないんですよ。もう本当にもう退院してからのかかる医療費って結構かかりますから。まあね、本当に後遺症に関しては何とかしてほしいですが、何が後遺症で何かこれは違うとか、分けることもできませんし、まあできればね、保証してほしいですけどね、そういったのは今は期待できないかなと。家庭の時ですから自助でやってくださいって言われますからね、ここの制度は。
Y en esas estoy, en ese momento estoy trabajando de depresión. Pero claro, es que si esto no tiene fin, ¿qué hacemos? Porque dentro de nada ya te dirán, pues tienes que ir a, ¿sabes? Y eso es una angustia, porque claro, es que si no puedes un trabajo.
The entire process of PIP has been so dehumanizing and horrible, to the point where I feel like over and over again I have to prove and articulate and specify specifically how my illness, my disability makes my life worse and makes it difficult, and open my entire life and existence wide open for them to say no, to specifically denigrate and to give frankly insulting means of rebuttal of me, just grinding. It's dehumanizing. It's a sense of not trying to find out your needs and your disability, but as if it's like a lie detector test.
The GP perspective, I absolutely get the fact that I am not dying and that there are more people with more serious conditions than me that the medical profession needs to give its time to. But my life has been completely turned upside down, and the lack of support has been galling.
Unfortunately, there was no like drugs or anything that she could give me. But she said, you know, take Tylenol, rest when you can, you know, try not to take on too much when you're feeling unwell. And those were really like the words of advice that she gave. She just kept saying, there's not enough research. There's not enough information right now as to what long COVID is or how to treat it, or, you know, so that was really the conversation. Even with the infectious disease specialist, it was the same thing.
Like I had hot lungs, I had sticky lungs. I appreciate that Dr. D uses my lung terminology when he's talking with me to like ask him questions, or he's like, you know, like understand the quality. And I do feel like there's a transactional component to the learning. You know, he shares what he does know. He stays up on the science and the literature that comes out. That's clear to me in our appointments. He's also, though, like, I think like he really does approach it as that partnership, and also like he, you know, I am someone that he is learning from. You know what I mean?
So recently, 3 days ago, lose the feeling in my hand for some time. My hands went suddenly blue. I have no confidence, to be honest, to contacting any doctor in regards to that, because it didn't help me in the past. So I'm not contacting anyone. I don't know. It's all my tests were fine. So whatever happens to me, there is not good answer, I guess, at this stage.
You had COVID and it was like a cold, like, what the hell are you complaining about? You know, so many people died from COVID and are dying from COVID. I think it contributes to my hesitancy or my hesitation, but I think my primary hesitation is like thinking it's a waste of everyone's time. So I think it's more just like feeling like there's not much that's known or can be done.
I think it should be more shown. Nobody wants to go through long COVID. Get it out there more. Get on the news. Go to the CDC and say, hey, if you want people to get vaccinated, say, you don't want to be a vegetable head like this woman here. It's life-changing.
Okay. So our interviewees also had a good many actionable ideas for how connections around long COVID can grow stronger. And I'm going to share just a few today, and then summarize some of the promise of narrative approaches to understanding disease. So one idea is a reminder that for patients, just knowing that someone is listening or cares or is checking in on you is huge, and it can make such a big difference. We had an explicit message from clinicians in the US study, quote, I know it's hard when they don't know there's anything that they can do, but hopefully they listen and can even anecdotally pass along to another patient who says that they're suffering with a similar kind of thing. Everybody wants their story to be useful to other people. Don't just look at your patient as a collection of symptoms, says another interviewee, but really listen to them and be that chief detective in helping them figure out what could be COVID and what might be something else. Patients hope to be connected, through their primary care or their long COVID clinic to peer support and other community resources. Support having someone in your practice, one interviewee suggested, who wants to do extra things to help people with long COVID. Do not chalk it up to mental illness. Take people seriously and meet them where they're at. Like, figure out where you can connect with them. Clinicians able to assist with getting benefits like short-term disability, or in the United States, we have a Family Medical Leave Act. I know that's different in the UK and other countries around the world. That's been really life-altering for people, and we've got another manuscript under review right now that's really focused on that part in the montage that you just saw, where people talk about how hard it can be to get benefits or to keep them over time. So people really want their clinicians to believe them, to persist with the paperwork, and also for systems to begin adapting to the reality that this is a very large intervention in people's ability to work and function in society. The social impact is enormous, but the social support systems have not caught up with that yet. So certainly some policy and system change implications from these narrative data. People also want very badly to be counted. And we heard a lot in the interviews, like, have a registry, make sure that this is documented in my medical record if you're my medical provider, so that you can come back to me when new science emerges. Tell me about other kinds of studies that I can be involved with. I want to tell my story, but I don't want my suffering to have been for naught. And then there's always this lovely sort of expression of gratitude. And I think that sometimes people who run systems and run social care programs and clinicians can be a bit frightened of the criticism that they might hear if they start listening more to narrative evidence. But what we see over and over again is prevailing kind of excellent judgment and a lot of gratitude. So as this participant put it, thanks so much for doing this, for taking care of people with long COVID, for being curious about our experiences, and for doing the research. I know it's frustrating and there's so much we don't know. I appreciate you doing this work, taking care of us, and doing research to identify new treatments. So let us all remember that people suffering with this are counting on people in the scientific community and in the medical community to continue doing right by them. We need science, we need stories, we need scientific approaches to stories. I think on the pitfall side, when it comes to narrative evidence, this danger of taking anecdotal stories and letting them drive policy as they sort of accumulate power on social media or get picked up in the traditional media. That's what we want to steer away from. What we want is the systematic approaches that we've been talking about, where we can learn together, we can have team science, we can continually refine our methods. But we know that we are looking for diverse perspectives and that we're listening hard to everything that we hear, not just one anecdotal story. But we know that whether we like it or not, our bodies respond to stories. They affect our heart rates, as well as our metaphorical hearts, our unconscious responses and our amygdalas, as well as our conscious thoughts. So keeping in mind that stories are essential, I think needs to undergird our approach and help temper our skepticism, because imperfect as stories may sometimes be, as a part of how we measure patients' experiences with health and healthcare, they're really, we can't do without them either. As cognitive scientist Mark Turner put it, Narrative imaging story is the fundamental instrument of thought. Rational capacities depend upon it. It's our chief means of looking into the future or predicting, and of planning and of explaining. So what are some elements of promise in the narrative approach? I think one is that it raises the alarm, and we really saw that with long COVID, but I think we also saw that with HIV and other emerging epidemics before there's any signs. I mean, sometimes we might be testing the groundwater and seeing changes that way, for example, but listening to what's happening to people is a really good way to see emerging issues in real time and be able to mount a response. It can define the issue and its parameters because it's not just a narrow data point. It is a rich and sort of multifaceted form of evidence. It can really highlight what matters to patients. At least in the US context, the research community pays a lot of attention to this sort of patient-centered design, patient-centered outcomes. And we also know from this recent publication from colleagues right there in the UK and other sources that people want to tell their stories more than they want to do check boxes on surveys. And so I think that's really a way to engage folks in science. It captures variation, as I've mentioned a few times in this talk, including at the flatter ends of the bell curve, where there may be less population, but a lot of important implication for how we address illnesses. Patients are amazing sources of ideas for solutions. My colleague Una Lee at Columbia University here has a wonderful portfolio of work on how patients' creative ideas can be well elicited and harnessed and used. Narrative approaches democratize science, which I think is really critical at this time when trust in science may be at a really worrying, if not all-time low, a significant low, at least in the sort of era of modernity. So getting people involved and making them feel like their input is part of generating rigorous and systematic evidence, I think, is crucial. And it's really holistic for us and allows us kind of like playing the piano. You know, you got your left and your right brain both engage with your two hands. Narrative evidence is a really great way to channel various aspects of our humanity. And I just want to close with this quote, which I love, from Albert Einstein. Everything must be made as simple as possible, but not simpler. I want to leave you with the thought that rigorously elicited and analyzed stories are part of getting the alchemy of understanding disease just right. You know, not too simple and not too complex. But I don't think boiling down only to data points that we use from the other august and wonderful branches of science always does justice to the complexity of experience and disease manifestation. I want to acknowledge the people who told their stories, folks in my lab, colleagues at the Wisconsin Research and Education Network, funding from the small grant, and also from our translational science folks and the DI colleagues around the world who put together the montage. And I want to thank you for having me today.
Rachel, thank you so much. That was absolutely riveting. Really, really interesting insights. We've got a few minutes for questions. We've got about 10 or 15 minutes for questions. Please do put your questions in the chat or raise your hand if you've also got a question. We've got a couple of questions in the chat already. I, at the moment, can't see anybody's hands because my view's... Here we go, I've got my speaker view. There we go. So if anybody wants to put their hands up, I can now see you. We've got a couple of questions in the chat. The first one is from Alison Powell. Alison, are you happy for me to ask this question, or would you like to ask it? Can't see Alison, I'm unmuting, so I'll go ahead and ask it. So Rachel, Alison says in the chat, she's just been at a training session on recruitment processes where they were discussing unconscious bias. And I wondered if there's scope for suggesting some interventions around that. For example, challenging unconscious bias that some healthcare professionals may have about long COVID, or indeed other poorly understood conditions. Did you have any reflections on that?
Yes, I think that's an excellent point. We have a doctoral student in the US who's actually been using our narrative work, not so much on long COVID, but on depression and on breast cancer, explicitly to develop training around unconscious bias. And she's been piloting that with my colleague Jill Jacklitz at the Center for Patient Partnerships. I think the narrative evidence is a wonderful way to get at this. The process of listening, not in real time, and being able to reflect on and identify your own responses as you encounter someone else's story, I think can be a very valuable tool. We used narrative evidence from our depression study in the US in a experiment controlled design in our medical school with medical students to see if we could get at bias and stigma as well as empathy. And we had wonderful results. We published that in Academic Medicine, and I can send that along to you as a resource. So I think the narrative evidence is really, really ripe for that. And I would love to know how you take it up and use it. That's part of the wonderful thing about the DIPEX methodology and community. These narratives are on the web. You can go use them. Go to healthtalk.org, go to healthexperiencesUSA.org, and to the other sites around the world. Go to DIPEX International. You can find them and harness them, right now and get going on your unconscious bias training.
Thank you, Rachel. And yes, just to say, certainly here in the UK, narratives, so the transcripts of interviews of Health Talk studies are available for secondary analysis. And do please drop me a message if you're interested in finding out more about that. So second question, Rachel, from Victoria, and this goes to the heart of discussions that I know you and I have had over the years. So could you talk a bit more about reaching those who are structurally disadvantaged to share their stories?
Yeah, I mean, I think this is always a work in progress. Maximum variation sampling is sort of the impossible dream, as my colleague Meg Gaines also calls it. So first of all, just, humility, like we never achieve it because experience is so multifaceted. I think we, as many people, are continuing to look at our own unconscious biases as researchers. I think we employ many diverse and creative sort of recruitment methodologies. We do deep stakeholder engagement. We try to democratize science within our own study teams, as well as through the sort of hearing and sharing of stories themselves. I think, we fail in the US and in many important ways. I think our own research community needs to become increasingly diverse. We have too many white researchers and not as many researchers of color involved in doing this. We are trying to pay really close attention to sort of issues of concordance. So yeah, I think the aspiration and the intention is really important. And I think the way it rolls out is a little bit better each time, because we are really committed to continuous learning, I think, in the DIPEX community globally. But we still don't hear from many people who have important things to say, and they may not want to engage in this method. I think there's always this push-pull, right? It's like, if you're the one initiating the research, it's still someone else joining. So I think having that antenna up for the patient-driven research that might be supported by people who work in academia. We had a wonderful instance in the US of doing work around experiences with cystic fibrosis, which was led by academics out of my university, including me. And then the subsequent study was led by one of the parents of children with cystic fibrosis who had been a co-investigator. And then she became the lead investigator and we became her co-investigator. So I think baby steps.
Great, thank you. And we now have a question from Mark. Mark Cabling, would you like to ask your question, or shall I ask it for you? Or will unmute you if you're wanting to ask it. But if not, I will go ahead. Rachel, question from Mark. The narrative evidence you've described is indeed rich and insightful. What sort of evidence methodology or methods do you use in analysing such data? You've touched on this a bit, but perhaps if you could expand a little bit for us.
Yeah, I think there is a range of analytic methods that can be employed in the US. Our team employs a sort of modified grounded theory approach where, we've had an interview guide and we've identified study questions and we've applied for funding and gotten it. But we also try to do as much of an inductive approach as possible, leaning into grounded theory. On a really practical level, the interview data, as you point out, are very rich. That means the transcripts are very long. So having a software program for analysis that you feel good about. We use MaxQDA, but I know other people use NVivo or Atlas T to try to sort of like manage the data and make sure that you're well positioned to really hear what's happening. So much more to be said on that, but aware of time, I'll leave it there.
Thanks, Rachel. If there's any more questions, please do pop them in the chat. But I'm just going to ask a follow-up question about the work you mentioned with the WHO and the learning that you've developed from this cross-country analysis. Could you tell us a bit more about where that's heading and what the WHO's response to these narratives, the form of evidence was, and what you think they're hoping to do with it?
Yeah, I mean, this is sort of just at the beginning, and I really want to give credit to Nicola Villaradorno of the Swiss team in the DIPEX community for forming that connection. But I would say that the World Health Organization is very curious about narrative evidence and how they might build an approach to using it. I think those conversations are right at the beginning. With respect to long COVID specifically, I think the montage and the summary of our rapid analysis of 167 interviews was very well received. We went on and gave a talk to the Global Health Network, which is sort of interdigitated with the World Health Organization, as I understand it, to share this more broadly. We're right now in a lot of conversations about sort of the difference between interviewing people so that they become spokespersons for a global, they sort of put a face on a global public health message, which is a valuable thing to do when you're trying to message and sort of mitigate and address an epidemic or disease issues globally. But that's very different to having a scientific approach to collecting diverse narratives and then sharing what is learned as a form of scientific evidence that may inform the development of other studies, the development of policies, and approaches, again, to sort of democratizing the scientific enterprise and rebuilding trust in it, which is something that I think many of us are concerned about.
Thank you. And we've just got a couple of minutes left. I'm just going to ask you a final wrap-up question about what's next for your long COVID work in research in the US. What are your plans with that?
Yeah, thanks. Right now we have a pilot grant to create a catalyst film summarizing a lot of what we've learned in the study and to work in a primary care clinic with that film and a sort of community resource guide to implement some of those ideas that I summarized patients suggested to us to try to help those at the point of care feel more efficacious and better capacitated while we wait for more effective clinical interventions, which we still don't have in great number, at least, to help with kind of the social impact, the trust building, the empathy, addressing unconscious bias, as Victoria and Allison and I think others have mentioned in the chat. So we'll be rolling that out next year and measuring and then hoping to take that to larger scale so that we really are using people's stories to improve care for others, which is what those we interview really very near and dear to them.
Well, thank you, Rachel. This has been an absolutely riveting hour. I really appreciate you taking the time to share this with us, and we'll keep watching this space and look forward to more research coming out from your group and others. So thank you all for joining, and thank you again, Rachel, for a really, really interesting talk.
Thank you. Thanks for having me. Nice to be with you all.
Bye, everybody. See you soon.